5%. 5% in medicine, everything can be made. चलो उधर चले जाओ. So just one test, frozen shoulder or no frozen shoulder. ठीक है. अभी क्या तकलीफ क्या है? उठा नहीं पा रहे. Inability to lift. So that patient will only, when I examined it was not. So again, weakness. So I see my no frozen shoulder test as a छोड़ दो ढीला, ये छोड़ 5%, but 95% I'm right. So I want to make things simple. So you do this test. This patient is not a frozen shoulder. I have to examine it, which means I want to see orthopedic. Orthopedic means pain. Neuro means no pain. He can't move the arm and he has no pain means neurosurgery, neurology. जो similarly, axial rotation. यहाँ छोड़ दो ऐसे बस छोड़ दो 1 मिनट जो यहीं छोड़. मैं अंदर दबाऊंगा आप बाहर दबाओ. यहाँ रुकिए इसे और मैं छोड़ूंगा ये अंदर पेट की तरफ भागेगी आप इसे भागने मत देना. Onward. That means this shoulder has no control of rotator cuff at all. I will always doubt whether there is associated neurological problem here. So I will examine his deltoid rotator cuff injury, but his deltoid is working. Once the deltoid is working, I have hope that I can do something to this joint, maybe repair the rotator cuff. In an elderly person, maybe replace it. Subscan, look at this, the PVC reading was normal, and ask him to press my hand down. He can't do it. He's a young guy. वो दिखाओ. And you can see how much he'll press. मेरा हाथ दबाओ नीचे. He can press. Mic level. Yeah, this is weak. Maybe because of pain. Sometimes you can't say. I can do other tests. अब जाओ.
आपके फ्लोर कॉन्सेप्ट में इंस्टेबिलिटी कहीं नहीं आई. It is supposed to be a ground floor problem. How will you diagnose that?
Yeah, so because I said in the beginning, this talk is based on.
Cart repair with a bony block procedure. This represents the highest level of surgical education, learning directly from a master surgeon.
Werewolf. Dr. ID, can you hear me?
I would like to give the details of the patient which is undergoing the surgery. The patient is a 45-year-old male who presented to our OPD with complaints of recurrent dislocation on the right side. The past history of first dislocation 25 years back, 140, and comparable to the left. Extension is equal to 30 degrees, which is also comparable to the opposite front.
Is testing the mobility of the labrum and the IGH. So on the right side we see the glenoid edge, and on the left side we are seeing the labrum and the IGH.
There seems to be some defect at around 3 or 4 o'clock.
I think that we can see
Bone loss is about 16%. Did you say about? Did you mention the bone?
No, sir. I didn't mention about the bone loss.
I did not try it. You know this patient? It was 16.
the rating was.
So he has released up to the level of the muscle, and the whole labrum has been released now. Now he is using the work to freshen the renal neck. Dr. ID,
Hello, yes.
आवाज आ रही है?
I hope. So what we consider now is this is a kind of boat. Such we have finished putting the ampules, amplifier anchor. I finished the regular released. Now I will harvest the scapular spine bone block. So I have here to the medial border of scapula. This is the deltoid fissure which I am rising. So we will harvest around 2 centimeters of scapular spine. And the cancellous bone from scapular spine. So the other iliac crest or non-hard instruments. I saw a corpse there. Corpse here. So,
So we have some problem in the communication with the OT. So now he is harvesting the bone block. In doubt, you can ask us. Table and shaped and prepared for the implantation of the glenoid. shaped and prepared for implantation.
Hello. Hello. And this will go and sit like this. So this will be the inferior part and this will be the superior part. So this is a good cancer wound which I have split. Okay, so hold it from here. So reshape it further here. We're lucky. Okay. Make a big holes and put the buttons in. So this goes in. It has both the functions of dual type basically. So buttons are open. Two buttons. I hope you can appreciate how solid bone it is. I have video silent. So this is almost 5 mm. You can see the marking 6, 7, 8. So this is 5 mm. So this will go like this. Okay. So this comes down the way. So we have prepared this. Now we will do the marking before the drawing. We'll mark the threads also because it can cause lot of entanglement, and we don't want any problems while we are inside the interior with the sleeve. Balance sleeve should be ready. Yes. So we are marking the inferior one at multiple levels, so that there is no confusion while we go inside. So this is going to be up, this is inferior part. Okay, so this is the up part and these are the buttons which are going to stay there. So I hope you can see this. We have prepared the bone block, and now we'll go back to the scopy part. So it can be off, spoon can be off. Open. So before putting that big cannula in there, I have to clear off the area, I have to clear off the data interval. So this is the area which I want to. I need a shaver. I need a shaver and a knife. Pull the bicep from the top. Yeah, perfect. So that's the advantage of having a highly trained assistant along with you. And the beautiful picture which is shown is all about seeing and doing. So if you are not able to see, you can't do it. So there is no fixed working quota view. So you have to take a pass into the labrum also before that camera comes in. Yes. So do it through. Then we will get a labrum. So that once the bone block comes in, we don't have to fit out. Okay. So here it is. Let's take here now. So we'll just. So we have to keep on one quarter to one. So these switching sticks come very handy. You need to have a couple of both. We'll cinch it. To give a vertical traction, this is very important. Yes. So, on my, in the mid, here portal, you pull in, pull out. Okay, perfect. So this has been cinched for our future fixation. So, alright, so we'll come. So we'll take out this camera now, put a stick, have an adequate amount of the subscap muscle nicely. So this camera goes in now. So if you put this camera, it takes some time, but your other steps will be very easy. That's the. So now I need the weave and the jig. So this is it, okay. After at 3 o'clock position, I need sleep. This is out. Sleep. Good night. Everything. Half time. parallel to it. So if the outside camera can show what's happening on the the bullets. So you keep it appealing intra-articularly. Will come intra-articularly once you put in the bullet. So the bullets come in. You should be very, very trained in all these because you cannot do. What is good? The pressure from here, no instrument to impact. So hold the camera. Hardcore opposite. Okay? So Mushi is on my left, so he is assisting me. Yes. Yes, left. Get right for you. Yeah. Yeah. Over it. There, so that nothing wrong here. So we want this to come out at the same time. Subject to be out, someone catch spreaders. So this spreads the muscle so that our button which is going to go and sit posteriorly seats onto it, seats onto the bone, and then which is sitting next to the bone. So here we are in the inferior one, the superior one. So to prevent the entanglement here, I need a 2.5 cut syringe. So where is the so this is the most crucial aspect. At times there can be a lot of instrument and playing with it. Hold this. So now we go ahead and pass our graph. We have done a camera and camera like this. This stays on the top and so this goes in this. Yeah. So wait here. Let us go the other also. Okay. So this is the last one. Hold the inferior also. Wait. We'll take out this range now. So someone need to hold. Okay. Now syringe already has the cut. So hold the camera. So swing it out. Okay. So you hold both the. So I need the elevator here. So someone needs to give the word. So I need wait. So how much is the pressure? Water is okay. So it has gone all around it. So hold. Okay, hold the inferior one. I don't want to damage the side also. So pull, yes. Great. Yes. So that's done. So that's what we wanted. And we are so we'll come back now.
And now let's move back towards the remaining talks of session 1.
Okay. So we'll finish it off. We'll go back again now.
I would like to request Professor Tarun Goyal sir to do the honor of presenting a memento to our respected chairpersons as a token of our appreciation. To take a seat on the podium and moderate the session.
Here. My mandate is to talk about shoulder x-rays and MRIs in clinical practice. Try to finish it as soon as possible. If I exceed my time, please let me know. Or if people are getting bored, Shashank, chup ho jaye. We do it in all the joints: elbow, wrist, knee, ankle. But somehow in shoulder, we are not, because of the peculiar anatomy of the shoulder joint, we are not able to do. One is from, suppose, like this, and one is like this. So you can have two lateral views, and I will take AP view. This is a regular AP view, and if you see, the anterior glenoid and the posterior glenoid are two distinct lines, and you can't see the glenoid. How to do it, I will not talk about it, but if you can appreciate the difference between the true AP and AP in your shoulder practice. So as I said, these are two distinct lines, and you must. Sometimes in proximal humerus fractures, for example, or after you've reduced, so in post-reduction on post-humeral or in proximal humerus fractures, sometimes you cannot do axillary view, and there you can do this. But it is good in proximal humerus fractures if there is a dislocation along with the fracture, the head is dislocated anteriorly, or if there is a tilt. Usually, many proximal humerus fractures are one of the, you need to, most of the things you will be able to discern in these two views. Help you to put your plate and everything. Decide where to put your plate, how many screws to go into head, so on and so forth. So make sure that you have got good x-rays and scan every time. You want to make sure that the screws are not piercing the humeral head. You want to make sure the plate is not too high. It is also important when you're, not only when you're operating on them, it is also important if you're treating them conservatively. Because many times we treat these proximal humerus fractures conservatively and we want to get serial x-rays done. Same views every time for first couple of weeks to make sure you don't miss out any slight deviation. Yes, CT yourself. It is, unless you know it, how to do it, your radiographer, whether you are in a government institute here or you're in a private practice yourself, will not be able to do it. Why view actually is not important, but once your radiographer gets used to doing Y views in cold cases, no injury cases, he will be able to do them in trauma cases too. Practice, it has totally replaced MR arthrography. When I started practicing and came back in 2008, I used to do about 4 or 5 MR arthrographies. So yes, if you get a 3 Tesla MRI, that means if you have got a 3 Tesla, you may not need MR arthrography. It has a quite good resolution. At least in rotator cuff and biceps. Rotator cuff and biceps pathology, not the intra-articular. If you have a good data, go ahead and do it. I have a thing you have to promise yourself today sitting here is, आज के बाद मैं रिपोर्ट नहीं पढ़ूंगा. ये जो रिपोर्ट पढ़ के सबसे बड़ी गलती होती है. You read the report and then you put your patients in 3 broad categories. Clinically, is it a painful shoulder? Is it a weak shoulder, or it is an unstable shoulder? All the entire spectrum of shoulder pathology. But if you can classify or you can divide your patient in one of the 3 categories, you will be able to read MRI with fair degree of accuracy in more than 90% of cases. And read the axial and sagittal sections. But start with coronal oblique. Most of the pathologies can be seen in coronal oblique. Not only that, it helps you get oriented in the MRI. It is not a jungle, it is not a maze. Sagittal view, and these are the sagittal cuts. So if you keep these x-rays, this picture of these x-rays on the back of your mind, it will help you read the MRIs. Okay, इसमें ये दिख रहा है, तो इसके ऊपर supraspinal. So the most common condition we see or more is painful or a stiff shoulder. It can be frozen. बहुत होता है, या हाथ उठ नहीं रहा है और आप पैसिवली भी नहीं उठा पा रहे हो, either because of pain or because of stiffness. Read the coronal and axial cuts. Very rarely you will find a rotator cuff tear where the supraspinal is intact but other cuff tendons are broken. It can happen theoretically, but usually it does not happen. So if in a painful or a stiff shoulder and the posterior cuff, which is attacked at the back, you will see a lot of tendinosis, tendinitis, frozen shoulder, and start treating that tear. You cannot treat that. These are just signal changes on MRI. It is just inflammation, some edema in the tendon, partial tear. As you all know, I'm sure in my MRI, the rotator cuff is okay, diagnosed. Theoretically speaking, there are a lot of findings in frozen shoulder. Almost 50% of times I cannot find them. They say there's a coracohumeral interval which is restricted, the axillary recess palsy. I'm sure there will be patients, and it is very easy to diagnose. You will not get MRI done. But weak shoulder in a shoulder practice means a rotator cuff tear. Now all you have to find out is how bad component or supra plus infra plus subscap, that is the anterior. How do we? We can find that out just by looking at these 2 cuts, the coronal and the axial cuts. So this degree of retraction, it is broken and it is gone medially. So this will only tell you about the supraspinatus. If you want, telling you how to measure how big is the tear, how much is the retraction, first try to start figuring out what is tone. And then at the back, this black line is going and attaching to the graded tuberosity all the way. That means posterior cuff is intact. My PGs ask me, sir, the posterior cuff, infra or teres, depending on how low the cut is. This is another thing, another seal of the height at the highest point of the humeral head. That means median retraction, or it has gone all the way at the level of the glenoid. If this edge of the supraspinatus has gone at the level of the glenoid or not. Even before operating, you need to give him prognosis. So while for diagnosis, coronal and axial cuts are enough. To give the prognosis,
surgery by Dr. ID, in which it was quite an advanced type of surgery in which he did an arthroscopic bone block procedure. I would like to take home, I'd like to advise my budding surgeons that they can go back when they start their Bankart surgery, they take home a few tips. They will use beanbag straps and pad all the bony pressure points, and the amount of traction is about 5 to 6 kgs, nothing more than that. Important thing Now the advantages are that this position about 50 to 70 degree abduction opens up the axillary space along with your lateral stands to the surgeon's left, and the Mayo instrument stand is placed on the right of the surgeon, and all the arthroscopy stuff is placed over. The static anesthesia team is a big boon for shoulder arthroscopic surgery. Now for the beginners, I would always suggest before putting the scope in, always draw your acromion, your clavicle, your coracoid, your AC joint and your supraclavicular fossa. What I do is I advise my juniors who are just starting the Bankart surgery, before stabbing it, just pump in some local anesthetic. So once you enter and make a stab incision, you enter, you feel a pop when your capsule gives way and you are sure you are into the joint, but still to be more sure, point on. This is the picture of dry arthroscopy you should be able to visualize before you start your fluids. Second important, your bites and suture, shuttle relay and everything is taking place. So it is usually done with the outside in technique, some leading edge of the subscapularis, and this trajectory of the spinal needle should be going towards the 5 o'clock position of the glenoid, so that your subsequent anchors and everything and your suture. Now the second important portal within Bankart surgery is the anterior-superior portal. This is the second anterior portal. It is made just close to the anterior-superior corner of the switched on your scope from the posterior portal to the anterior-superior portal. See how nicely you can look right down to the glenoid neck and you can work over it and away from the biceps tendon, because this avoids the crowding of the cannulas in the rotator interval. So again, put a switching stick and then shuttle your report. And you can put a 5.5 mm cannula for suture portal, the posterior portal, which is the viewing portal, and then becomes the working portal, and the anterior inferior portal, which is the workhorse portal, and the inferior glenohumeral ligament from the anterior inferior surface of the glenoid rim, and it is still known to be the medial or lateral condyle of the femur or the tibia. It is, you can try to peel it off, and if this tear is extended right from the 3 o'clock with the shaver along with the RF to control the bleeding. These are the important steps to mobilize your labrum. Free the tissues right down to the surface of the glenoid, then your mobilization is complete. If you are able to see the muscles of the subscap, then your mobilization is good and complete. After you have done the adequate mobilization, you decorticate the glenoid using a rasp of a shaver, but do not your inferior part right down from the 3 o'clock position to the 5 or 6 o'clock position. Control the bleeding, hold the labrum and try to one of them, because there are reasons for that. So use a sleeve, use a proper drill bit which comes with the set to drill your anchor. The first anchor is also. So like this picture shows, anchor placement, if it is done at the edge, will produce a iatrogenic ALPSA type of lesion in which your labrum does not come up. We are happy to put at least 3 anchors, even more 4 anchor points if you go through the literature, and the more the fixation points. Now as we saw in the live video, there was a special device called as a suture anchored lasso shuttling the medial side, but also from south to north. So south to north shift is also important than from equally important or even more important than west to east. So this video shows how we are again rasping 5 o'clock or 5:30 position. Try to avoid, this is an old video, and park it in the posterior portal by a crochet hook or a suture grasper device. This suture will be shuttled through the lasso or the biter. Take it again outside the posterior portal, tie it with the suture limb which we have passed and parked it before, and then shuttle this suture device, this suture limb, and does not come and sits over the glenohumeral joint and rubs against the humerus. It is parked away from the glenohumeral joint. Now as I told you, your knot tying should be very secure and very meticulous, because in the first few weeks, it is going to take all the brunt of your. This has some cases that the knot can be stuck in the middle. So a safest option would be to practice your Duncan sliding. Video is not working. So go back and you can see on the videos on the YouTube, capsular labral tissue right down to 6 o'clock position and up to 7 o'clock. Very important. Rasp, lead the anterior glenoid neck. Don't be afraid of bleed. Just don't do a putty plat, please. Always shift it from inferior to superior portion, all your tissue, so that the redundant axillary. Again, practice before you go in and start doing your Bankart's repair. And before I end, this is the last slide. This is not an essential step of surgery, but it's a la carte approach. All rehab programs which are devised and put on the physiotherapy chamber are not going to work for every patient. Depends upon the, and once he has got a sufficient range of motion, then only start your strength training after that. And I always avoid.
Can I invite Dr. Sharad? Sharad Khanaka for a strong only life surgery on arthros.
All the speakers for their insightful presentation, and to our chairperson for leading the session. As a token of our
shoulder arthritis is another option. I have my residents who said to keep on getting physio done for frozen shoulder without getting an X-ray done. So it's and 3 chairs to the BATHINDA Orthopedic Association for organizing this 3rd BATHINDA shoulder case. 3 chairs. Get a hand to it. Thank you. Just to make you guys. Sorry guys, we'll just put the laptop on because it's a real life thing. So this is the desi jugaad that we have for the beach chair. One guy who helps us with the implant. So we asked to make a video by showing an external view as well as the view of the screen is supported. So we'll finish this quickly. About it, we can have use a Spider-Man for the same, but otherwise that's how you go about it. So you mark your shoulder. Normally I do it after the patient is laid, just for the purpose of demonstration that you said you make your markings. The way I was trained from my fellowship is you keep your viewing portal where it is, and you use a needle from a separate little lateral sort of entry. So diagnostic round, I will not waste time on, and then you would want to clear that defect out. So you can use a shaper for the same, you can use an end cutter for the same, or you can use a rasp to rasp it out. Now again, conferences you go about, people talk about using one anchor. So the trick to get the anchor in is to use a screwing motion. When you put that anchor to make sure it goes in, have somebody tap it for you. Okay. I'm putting 2 anchors. This clip is to show that sometimes the orientation of the needle that you want, or the orientation of the anchor that you want, is not actually how you want it. So this is the same that you grab hold of one of the suture limbs, either loose of the legs or one of the tigers or one of the legs. And it's important to teach your resident who's holding the limb with the sutures to hold one tight. जो टाइट पकड़ा है इसको ढीला छोड़ो, उसको ढीला पकड़ा है, उसको टाइट छोड़ो, same thing here. And I'm morbidly afraid that they are actually cut out. So once I get a loop out, it's easier for me, maybe telling you last point is after you've done your Bankart repair and everything, the last thing you do. And I think this is fairly standard for everybody, the same thing. As promised, not much time taken.
Just a quick question.
And as we know that it is a salvage kind of procedure when everything got failed. So you move to the letarge, or at times the patient comes to you when you need to. So again, steep learning curve for the arthroscopic things, but letarge is a one thing which you can learn easily, and you can reciprocate that same in the amplissage done, Bankart repair done, but this patient ultimately landed into a recurrent shoulder dislocation even after the this. And this is again we can see on the anterior aspect the whole of the labrum is again torn, which was repaired, and there is lots of edema on the anterior aspect. Alright, so no worries.
Put a straight incision of about 5 centimeter from coracoid to the axillary fold. Then we follow the soft tissue dissection. So once that plane is identified, that fat plane, the cephalic nerve is dissected out and followed by its retraction. Then using the finger, we can reach to the conjoint tendon. So this white shiny structure in front is the conjoint tendon. Minor muscle attachment and the interval between the pectoralis minor complete the dissection and erosion of pectoralis minor from the medial surface of the coracoid. Scissor, and the coracoid is set free for the osteotomy. So we can mark now the temporary screw positions, and beyond that we can the attachment of conjoint tendon. Now you can take the coracoid easily outside. And it should not splinter the bone, and then we drill the holes in both the screws.
Coracoid bone and prevents or avoid any splintering of the bone. So this can be utilized during the surgery to hold
right of the vision of the surgical field. Then we identify the subscapularis and the plane between the upper 2/3 and superior and inferior aspect. The muscle is retracted and a white glistening is extracted. Our job is easy. Now you could able to easily visualize the glenoid surface, and nibble it out to create a good bleeding bed. So you use osteotome, periosteum. You can decide the placement of one of the screw and can drill hole nearly parallel to the glenoid surface, and position and screw length which was already there in the coracoid by putting another solid partially threaded screws. Conventionally, and after complete tightening of the screws, check for the stability of the graft, which should be flush with the glenoid surface to prevent any arthritis. So now we are going to see the sling mechanism of the biceps, and you can see the biceps is functioning as a sling between the.
Should be knowing which structures to pull and when to pull and how to pull. So usually if you become good in dissection, you could able to finish. Is very small. That is also very important, which gives a very good cosmetic result to the patient also. So just try to.
Next, I would like to invite Dr. Ravi Mittal for most talk on assessment of tear size and repair.
Good morning. Thank you, Dr. Tarun, Dr. Pankaj, for this invitation. I've been given to speak on assessment of tear size on AB and medial lateral plane by imaging using MRI or ultrasound, or you can do it on. What's the correlation of the tear size and its repairability? I think it's controversial. I think the repairability cannot be predictive. The two terms are not synonymous. They don't carry the same meaning, and they should be distinguished. The size is not, a big size does not mean that it cannot be repaired. And you aim for tension-free repair. So, whenever you shift here, you pull the cuff from medial to lateral, it reduces, and that's how you identify that it is crescent shaped, and you put your anchors and sutures accordingly. Medial to lateral, it is not reduced. You have to pull it at an angle from, say, postero, and it is the tear pattern, how you reduce it, place the anchor and sutures, that matters most about your. We have done preliminary bursectomy. We see it from the posterior portal, and that's a 2 tendon cuff tear to the footprint of the anchor. It is 3. So to the lateral margin of the footprint, it will be either 4 or 5. In the AP plane, and he says it is difficult to repair because of poor